You can look at heterogeneity in Alzheimer's disease from different viewpoints. And one of those, and I think the most obvious viewpoint, is the clinical viewpoint. So we recognize heterogeneity in the clinical presentations that patients have. And for our study, we looked at 3 different clinical variants. So we had patients with typical amnestic Alzheimer's disease. We had 6 patients that presented with more behavioral or dysexecutive problems during life, more so than their memory complaints. And we had 3 patients that had what we call posterior cortical atrophy. So in that case, patients present with visual spatial problems. And we looked at the distribution of amyloid beta and phosphorylated tau, because that are the proteins that aggregate in Alzheimer's disease pathology. But also we looked at neuroinflammation, because neuroinflammation plays a big role in Alzheimer's disease pathophysiology. Now, we confirmed what others already shown, is that the distribution of phosphorylated tau is different between those clinical variants. But we also show that the distribution of neuroinflammation is different. Now, neuroinflammation is a process in which the central nervous system gets inflamed. And the key players in neuroinflammation are microglia and astrocytes. And we looked into the distribution of those activated microglia and reactive astrocytes. And we saw that not only there's a difference in distribution between those clinical variants, but also that there's a difference in the cell type that is mostly involved in that neuroinflammation. So in typical amnestic Alzheimer's disease, we found neuroinflammation consisting mostly of activated microglia in the hippocampus, which is a brain region that is very important for memory. In behavioral dysexecutive, we also found activated microglia in the hippocampus, but also very much in the middle frontal gyrus. Now, for posterior cortical atrophy, so in which patients have visual spatial problems, we saw some activated microglia, but it was not the most prominent inflammatory involvement that we saw. It was mostly that reactive astrocytes in the parietal cortices that stood out in this clinical variant. So not only is there a difference in distribution, but also a difference in cell type in our different clinical variants. It's super interesting because, yes, all Alzheimer's disease patients have plaques and tangles. That is needed for the diagnosis of Alzheimer's disease. But if it's different cell types in different types of patients that are more involved in this pathophysiology, that might has consequences for how to treat these different clinical variants. So maybe in typical and in behavioral dysexecutive, you want to target the microglia, whereas in PCA, posterior cortical atrophy, you might want to target the astrocytes rather than the microglia. Now, of course, these are big statements. This is a pathology study, so we only look at one moment in time. We don't see the whole longitudinal process, and that might be of influence of what we see. But I do believe that, there are different innate immune responses for different types of patients. So although they all have plaques and tangles, the reactions of the innate immune system may very well differ and may very well need different targets or therapeutics.